بسم الله الرحمن الرحيم. I'm Dr. Mohamed Nasr, a professor of hematology, and my talk will be about the megaloblastic and aplastic anemias. Here is my contact information. And the agenda will include the erythropoiesis, morphological classification of the anemias, megaloblastic anemias due to either vitamin B12 deficiency or folic acid deficiency, the differential diagnosis of the pancytopenias, aplastic anemias, and lastly, case scenarios. Here is the normal erythropoiesis that occur in the bone marrow cavities. The process involves a gradual decrease in cell size, condensation, and eventual expulsion of the nucleus, and the increase in hemoglobin production. As you see, the series of chains will end in formation of the reticulocytes. The reticulocytes is the only cell that is capable of leaving the bone marrow and appear in the peripheral blood. It will stay for 24 to 48 hours to complete its maturation to the normal red blood cell. Here is the normal red blood cell, which is the flexible and oval biconcave disc. It lacks the cell nucleus. It lacks most of the organism, and this allows the accumulation of the maximum amount of hemoglobin. The mean corpuscular volume is one of the blood indices. It means the average red blood cell volume expressed in femtoliters. And the normal range for the MCV is 80 to 99 femtoliter. And according to the MCV, the red blood cell can be either macrocytic with MCV below the normal range, or normocytic with MCV within the normal range, macrocytic with MCV above the normal range. So, according to the MCV, the anemia can be classified to these three subtypes of anemia, either macrocytic, normocytic, or macrocytic anemias. Here is the morphological classification, the etiology of the anemia according to the morphology. And here is the macrocytic anemia, which is sometimes associated with megaloblastic chains in the bone marrow, or not associated with megaloblastic chains in the bone marrow. When it is associated with megaloblastic in the bone marrow, we call it megaloblastic macrocytic anemia. It can be caused by vitamin B12 deficiency or folic acid deficiency, while the non-megaloblastic macrocytic anemia can be seen in case of alcoholism, pregnancy, smoking, hypothyroidism, liver disease, hemorrhage, hemolysis, and aplastic anemia. The megaloblastic anemia, by definition, it means macrocytic anemia associated with megaloblastic chains in the bone marrow. The general features of megaloblastic anemia, the mechanism that cause megaloblastic states include deficiency or defective utilization of vitamin B12 or folic acid deficiency, results from defective DNA synthesis, while the RNA synthesis will continue, resulting in increased cytoplasmic mass and maturation. Macroevaluatic red blood cells enter the circulation, and all the cells have the space in which cytoplasmic maturity is greater than the nuclear maturity, producing megaloblasts in the bone marrow. This space increase intramedullary cell death, what's called an effective erythropoiesis, will result in direct hyperproteinemia and hyperuricemia, because the space can affect all the cell lines. Leukopenia and thrombocytopenia may occur. And another hallmark for the megaloblastic state is the reticulocytopenia from defective erythropoiesis. Hypersegmented polymorph nuclear neutrophils is a standard finding. So, what about the megaloblastic anemia due to vitamin B12 deficiency? We have mentioned that megaloblastic anemia can be caused by vitamin B12 deficiency or folic acid deficiency. We'll start with the vitamin B12 deficiency. The vitamin B12 is available in meat and animal protein foods, so many. The absorption of vitamin B12 in the food bind to binding protein called R binders in saliva that protect B12 in the acid medium of the stomach. Its absorption occurs in the terminal ileum and requires what's called intrinsic factor, a secretion of gastric mucosa secreted by the parietal cells for transport across the intestinal mucosa. When this B12 complex, which include B12 in addition to the R binders, enter the small intestine, pancreatic enzyme cleave it, and the vitamin B12 binds to the intrinsic factor. Vitamin B12 is present in the plasma as hydroxycobalamin bound to the specific protein transcobalamin 1 or 2. Transcobalamin 1 is the storage form, while the transcobalamin 2 is the transport protein. Because of the slow rate of utilization and considerable tissue stores of vitamin B12, deficiency usually takes many months to years to appear. Liver B12 stores are normally sufficient to sustain physiologic needs for 3 to 5 years in absence of intrinsic factor, and for 6 months to 1 year in absence of total enterohepatic reabsorption capacity. The function of the vitamin B12, it is essential for red blood cell formation, neurological functions, and DNA synthesis. The pathophysiology, when DNA synthesis is impaired, the cell cycle can progress from the G2 growth stage to mitosis, which is the M stage. This leads to continuing cell growth without division, which present as macrocytosis. The pathological state of megaloblastosis is characterized by many large, immature, and dysfunctional red blood cells, what's called megablasts and the bone marrow, and also by hypersegmented neutrophils, defined as the presence of neutrophils with 5 or more loops. These hypersegmented neutrophils can be detected in the peripheral blood and in the bone marrow. Most megaloblasts are destroyed prior to entering to the peripheral blood, what's called intramedullary hemolysis. The etiology of vitamin B12 deficiency, inadequate intake, loss of intrinsic factor secretion with a special form of megaloblastic anemia called pernicious anemia, blind loop syndrome because of the bacterial utilization of vitamin B12, fish tapeworm infestation, which utilize the vitamin B12, congenital absence of ileal absorptive sites, regional enteritis, chronic pancreatitis, and drugs like oral calcium chelating drugs, aminosalicylic acid, and biconnite. The clinical picture in case of vitamin B12 deficiency, vitamin B12 deficiency causes a wide range of hematological, gastrointestinal, psychiatric, and neurological disorders. The hematological presentation of vitamin B12 deficiency range from the incidental increase of mean corpuscular volume and neutrophil hypersegmentation, which can be discovered on routine checkups for CBC for any reason. Symptoms of anemia such as fatigue or dyspnea on exertion. Sometimes the anemia is severe enough leading to congestive heart failure with its manifestation like the ankle edema, orthopnea, and nocturnia. Neuropsychiatric symptoms may precede hematological signs and are represented by myelopathy, neuropathy, and dementia. The spinal cord manifestations with subacute combined degeneration is characterized by disturbance of position, sense, and spastic paraparesis or tetraparesis. Here is one of the manifestations of vitamin B12 deficiency, what's called atrophic growth sites. As you can see, the difference between the pictures on the right and the picture on the left with loss of papillae of the tongue. So the tongue appears glazed with atrophy of the papillae. Sometimes the patient may have a lemon yellow hue due to the combination of anemia and increase in the bilirubin level. The source of bilirubin is the intramedullary hemolysis. Now, how we can diagnose vitamin B12 deficiency? The gold standard for the diagnosis of vitamin B12 deficiency is the low blood level of vitamin B12. Optimal and functional range of serum B12 range are likely between 800 to 1000 nanogram per liter. Other findings, we can see decreased red blood cell count and hemoglobin level with macrocytes larger than normal red blood cells. So we'll find there is increase in microvascular volume, usually is above 100 milliliter, decrease in reticulocyte count, and the destruction of fragile abnormal megaloblastic erythroid B corpuscle. The platelets can be reduced. Neutrophil granulocytes may show multi-segmented nuclei. Anisocytosis with increased variation in the red blood cell size or biochitocytosis with abnormally shaped red blood cells. As you can see here is a peripheral blood smear with macrocytes, macroevaluocytes, and hyper-segmented neutrophils. After B12 deficiency established, the pathophysiologic mechanism must be identified. As a principle, the anemia is not the complete diagnosis. I have to look for its etiology to be able to correct the etiology, and so I can treat the patient. So if I have a case of vitamin B12 deficiency, I have to look for an etiology, and you have to revise all the etiologies or the possibilities of deficiency of vitamin B12, including what we have mentioned, the pernicious anemia. Pernicious anemia is a subtype or a special type of megaloblastic anemia caused by autoantibodies directed against the parietal cells or the gastric parietal cells, which are the cells responsible for the production of intrinsic factor. So I have to look for autoantibodies to the gastric parietal cells, which can be identified as 80 to 90% of patients with pernicious anemia. And more important, for diagnosis are antibodies directed to intrinsic factor itself, which can be found in the sera of most patients with pernicious anemia. Chlorohydrin is present in most patients with pernicious anemia. And here is the pathogenesis of the pernicious anemia with formation of antibodies against the parietal cells. So there will be no intrinsic factor and no absorption of vitamin B12, and consequently the patient will suffer from pernicious anemia. The treatment, first I have to look for the etiology, and I have to correct the etiology. Second, I will supplement the patient with the deficient factor. So B12 can be given as hydroxycobalamin intramuscular with 1,000 microgram. The initial dose at 6 times over 2 to 3 weeks. Then the patient can be maintained with 1,000 microgram every 3 weeks. We have a special warning here, as on a clinical level, there is much similarity between vitamin B12 deficiency and folic acid deficiency. And if large doses of folic acid are given in B12 deficiency, they cause hematological response, but on the other hand, may aggravate the neuropathy. So folic acid should therefore not be given alone unless B12 deficiency has been excluded. And in severely anemic patients who need treatment urgently, it may be safer to initiate treatment with both vitamins after blood has been taken for B12 and folic acid assay. The criteria of a good response to your treatment. So after initiation of therapy, reticulocytes begins to increase around third day and gradually returns to normal by the end of third week. The hemoglobin should rise by 2 to 3 grams per deciliter each 2 weeks. The white blood cells and platelets count has become normal within 7 to 10 days. The bone marrow is normoplastic in about 48 hours. The peripheral neuropathies may partially improve within 3 to 6 or even 12 months, but the spinal cord damage is irreversible. Prophylactic therapy to avoid the deficiency of vitamin B12. So vitamin B12 can be given 3 monthly to patients who have total gastrectomy or ileal resection. Next, we'll move to megaloblastic anemia due to folic acid deficiency. Many plants and animal tissues contain folic acid. Absorption occurs in the duodenum and the upper jejunum, and no need to intrinsic factor. They are bound to protein and transport as methyl tetrahydrofolate. The serum level vary from 4 to 21 nanogram per ml. The etiology and pathophysiology of folic acid deficiency. Liver stores provide only 2 to 4 months supply in absence of intake. Causes prolonged cooking. This will destroy the folate and intestinal absorption. Drugs, which can decrease absorption as anticonvulsant therapy or oral contraceptives, interfere with the folate metabolism, like the antimetabolized methotrexate and antimicrobial drugs like the trimethoprim. Increased demand for folate can occur in pregnant and lactating patients, chronic hemolytic anemias, patients on long-term dialysis. The diagnosis of folate deficiency activities can be differentiated from B12 deficiency in regard to peripheral blood and bone marrow findings, but the neurologic lesions, as seen in vitamin B12 deficiency, do not occur. The primary laboratory studies reveal measurable folate depletion. Serum folic acid level is below 4 nanogram per ml, suggests a deficiency, but the optimal and functional range of red blood cell folate range are likely between 1000 and 1500 nanogram per ml. The treatment, after the treatment of the cause, the patient should be supplied with folic acid between 1 to 5 milligram per day. Usually it will be taken as oral tablets. This will be quite enough to replenish the tissues. The prophylaxis folic acid is given in pregnancy as a recommended dosage of 400 microgram per day. Folic acid is also given to patients undergoing chronic dialysis and with severe chronic hemolytic anemia and premature babies. So here is the difference between vitamin B12 and folic acid deficiencies on the clinical level. As we have mentioned, folic acid deficiency can be associated with anemia and atrophic glycocytes, but no neurologic affection, while the vitamin B12 deficiency can be associated with anemia, atrophic glycocytes, and neuropathic changes. So as we can see, the CBC in case of vitamin B12 deficiency or folic acid deficiency can present with pancytopenia. So we have to know the differential diagnosis of pancytopenia, which include aplastic anemia, myelodysplastic syndrome, bone marrow infiltration by Hodgkin or non-Hodgkin lymphoma, multiple myeloma, metastatic carcinoma, myelofibrosis or myelosclerosis, hypersplenism, paroxysmal nocturnal hemoglobinuria, or overwhelming infection. This is in addition to the megaloblastic anemia, either due to vitamin B12 deficiency or folic acid deficiency. So now we'll move to the aplastic anemia. So the aplastic anemia, by definition, it is a type of anemia resulting from a loss of red blood cell precursors, either from a defect in the stem cell pool or an injury to the microenvironment that supports the marrow, and is often with borderline high MCV value. The term aplastic anemia commonly implies a band hypoplasia of the bone marrow with leukopenia and thrombocytopenia. So the aplastic anemia is some sort of misnomer because it will include, in addition to the red blood cells, it will include also the white blood cells and thrombocytopenia, and present with usually use pancytopenia. We have the special form of aplastic anemia, what's called the pure red cell aplasia, which implies a mechanism selectively destructive to the erythroid precursors. Here, pure red cell aplasia will be restricted only to the erythroid precursors. The etiology and pathogenesis, about half of the patients are idiopathic. Some recognized causes are chemicals like benzene and organic arsenic, and radiation, which are toxic to the stem or to the microenvironment. Drugs like the antineoplastic, antibiotics, mainly the chlorphenol, non-steroidal, non-inflammatory, and anticonvulsants. Viruses, aplastic anemia occur as a rare sequelae of infectious hepatitis, usually develop after recovery and commonly associated with epidemic hepatitis infections, mainly the hepatitis A. Chromosomal abnormalities, a rare form of anemia called Fanconi anemia, a type of familial aplastic anemia with bone abnormalities like microcephaly, in addition to hypogonadism and brown pigmentation of the skin. The clinical features of aplastic anemia. The onset of aplastic anemia is usually insidious, often occurring over weeks or months after exposure to a certain toxin, but sometimes it is acute. Signs vary with the severity of the pancytopenia due to affection of the red blood cells, so the patient will suffer from manifestations of the anemia. Thrombocytopenia, if it is severe, it will be associated with bleeding, either to the skin or the mucous membrane. The white blood cells, sometimes so severe, also associated with even with agranulocytosis, with life-threatening infections. Characteristically, splenomegaly or organomegaly in general is absent in case of aplastic anemia. The symptoms of pure red blood cell aplasia are generally milder and relate to the degree of anemia or to the underlying disorder. The laboratory findings in case of aplastic anemia, the red blood cells are normocytic, normochromic, sometimes marginally microcytic. White blood cell count usually is less than 1,500 per microliter, occurring chiefly in the granulocytes. Platelets are often markedly reduced. Reticulocytes are decreased or absent. The bone marrow aspiration is cellular, while the bone marrow biopsy is mandatory in such a case for the diagnosis and show replacement of the normal hematopoietic elements with fat cells. In case of pure red cell aplasia, as we have mentioned, the bone marrow cellularity and maturation may be normal except for complete absence of erythroid precursors. So the brunt of affection in case also pure red cell aplasia will be on erythroid precursors only. Here is the findings in the bone marrow biopsy. To the left side, it is the normal bone marrow. It shows overall cellularity between 30 to 70%, with the remainder of the space being occupied by fat and stroma. While in case of aplastic anemia, the bone marrow biopsy is shows virtually no hematopoietic cells, and the marrow space consists of fat cells and stroma. No hematopoietic elements in the case of aplastic anemia. The risk stratification, this will help in the selection of therapy. Aplastic anemia can be classified according to the following criteria. To severe aplastic anemia, here the bone marrow cellularity less than 25%, at least two of the following: peripheral blood absolute neutrophil count less than 500 per microliter, platelet count less than 20,000 per microliter, and the reticulocyte count less than 20,000 per microliter. The very severe aplastic anemia, it will include all the criteria, but here the absolute neutrophil count is less than 200 per microliter. The non-severe aplastic anemia, it will show hypoplastic or hypocellular bone marrow as described for the severe aplastic anemia. But here the peripheral blood cytopenia not fulfilling the criteria for severe aplastic anemia or the very severe aplastic anemia. The treatment will start with the supportive care, including the transfusion for the red blood cells or platelets according to the need of the patient, use of the antibiotics for both prophylaxis and therapy. The aim of the treatment is the restoration of the cellularity, so and can be accomplished by anti-thymocyte globulin, the cyclosporin, or the combination of the two. And the rationale for the use of these immunosuppressive agents is to suppress the T lymphocytes or the cytotoxic T lymphocytes, which is in most of the cases responsible for the destruction of the stem cells. Use of cytokines is to enhance the proliferation of the precursors like the erythropoietin, to enhance the erythroid precursors, granulocyte or granulocyte macrophage colony-stimulating factors, to enhance the proliferation of the white blood cells. Androgens is anabolic and it is effective in some cases. Bone marrow transplant from an identical twin or an HLA compatible sibling will be curative in most of the cases. Here, the first case scenario was a 75 years old man referred by his urologist for investigation of anemia. He has type 2 diabetes treated with metformin. On examination, he is pale, had mild edema, and minimal loss of position and vibratory sense in the feet bilaterally. Laboratory evaluation reveals a hemoglobin of 7.1 gram per deciliter with MCV of 109 femtoliter, neutrophil count was 960 per microliter, and platelet counts of 35,000 per microliter. So what do you think about the CBC finding regarding the hemoglobin level, neutrophil count, and platelets, and what the type of anemia in such a case? What do you think is about the neurological insult? How you can correlate this type of anemia and the neurological insult? What is the most probable diagnosis? What are the investigations needed to confirm your diagnosis? What do you think the cause of this condition? Remember, the patient is diabetic and is taking an oral medication called metformin, which is one of the bygone nights. The second case scenario is a 24-year-old female present with fatigue and dyspnea on exertion, which has been progressive over the last 2 months, associated with a bleeding manifestation. She is on no medications and has no significant past medical history. Her physical examination is significant for skin pallor and pale conjunctiva, purpura, ecchymosis, but no organomegaly. The laboratory evaluations reveal hemoglobin of 6.4 gram per deciliter, MCV 89 femtoliter, and the correct reticulocytic count of 0.3%, white blood cell counts and platelets are reduced. So can you describe the CBC finding and comment about the reticulocytic count? What is the most probable diagnosis and what are the investigations you need to confirm your diagnosis? And thank you.